Welcome everyone, and thank you for joining us today for a webinar on child maltreatment and duty to report. I wanted to take a moment in the spirit of truth and reconciliation to acknowledge that Saskatchewan is located on treaty lands 2, 4, 5, 6, 8, and 10, and is homeland to the Métis people. I reaffirm our responsibilities and commitment to healthy relationships between Indigenous and non-Indigenous peoples. At the Prevention Institute, we are committed to understanding the history and legacy of colonialism and playing a part in disrupting harm in our work and personal lives. So for those who are not familiar with the Saskatchewan Prevention Institute, I'm going to take a moment to introduce it. So for over 40 years now, the Saskatchewan Prevention Institute has provided primary prevention services throughout Saskatchewan to reduce the occurrence of disabling conditions in children. Our definition of disabling conditions is holistic, with the aim of providing children with opportunities to grow and thrive to the best of their abilities. We provide evidence-based, current and emerging information and strategies to professionals working in a variety of settings to help enrich and support the work that they are doing with children and families. We provide resources for professionals and public, training and workshops, multimedia information campaigns, and provincial and national networking opportunities. So staff of 5 programs at the Prevention Institute have collaborated to form the early childhood team, and collaborating on projects can increase our reach and our opportunities to focus on early childhood well-being. And one of the collaborations is to facilitate a webinar series focusing on early childhood well-being. And as part of this series, we invited Dr. Weiler to present. So Dr. William Weiler is a pediatrician in Saskatchewan and an assistant professor at the University of Saskatchewan. And Dr. Weiler provides child maltreatment assessment services at the Pattison's Children's Hospital. So thank you, Dr. Weiler. I'll hand it over to you now.
Thanks very much, Megan. Like the introduction says, I'm William Weiler. I'm one of the pediatricians here at the Pattison Children's Hospital. I'd like to say I'm newly back, but I guess today is the last day of my first year, so starting tomorrow will be my second year back. I'm originally from Saskatchewan. I did do my medical training here in the province, and I did do my pediatric residency here in the province, and and then I went off to Toronto for a couple of years to get some specific training in child maltreatment pediatrics, and I did a fellowship there. So I'm bringing that as kind of a newer area of medicine to Saskatoon, back to kind of set up a service here. And I work in coordination with the Child and Family Medical Services team in Regina, who has been established a much more longer time, and provide kind of similar services in Regina. All right, so the only disclosure I have to make is I am financially compensated in the form of this is my job, this is what I do, and as part of my ACFP contract with the university, I'm added to kind of help educate whoever wants to learn about child maltreatment services. So I am paid for this as part of my position. And I did want to give a bit of a disclaimer that although I don't have anything, I don't have graphic photos in here, I don't have anything that should necessarily set anybody off. We will be talking about kind of child abuse and child maltreatment and various presentations. So this can be quite upsetting to many people. And this is kind of me giving you permission. If you need to take a break and step away, that's totally fine. It's very easy to do, obviously online, but even if we're in person, that you certainly can take that time to protect yourself. These are the kind of different areas that I was hoping to chat about today, or the different kind of milestones I was hoping to meet. So I want to start with a bit of an overview of what does the situation look like in the world? So what's going on? How big of a problem is this everywhere, and then also more locally? And then I just wanted to do a quick review of roles about kind of who everyone is in this child protection system, what kind of responsibility everyone has. And part of that is kind of what your responsibilities will be kind of in your interactions with families and clinic, sorry. there are, I also want to talk about red flags for child maltreatment. So these are the few things that you guys can watch out for when you are looking, sorry, just give me a moment. Sorry, I think they're scoping out new real estate and for the office that I'm looking in. So we'll also talk about some we'll talk about some red flags to look out for and things that for you to be aware of. And then when you guys are concerned, what the process is to how to report, what that duty report is. So first section is kind of talk about child maltreatment around the world. So what exactly is child maltreatment? Well, there's a lot of different definitions, but really it is a wide variety of different ways that a child can be maltreated or mistreated. So that can include physical abuse, that can include sexual abuse, or neglect, or all sorts of other types of exploitation. One of the important things to recognize is that harm does not necessarily need to have happened. There just needs to be the potential for harm for something to be maltreatment. So we don't have to wait for something to happen. We just have to have a reasonable doubt or reasonable concern that a negative impact could happen to a child. Around the world, though, these kind of numbers are a bit mind-boggling, but nearly kind of 75% of kids in the early couple of years, so toddler to preschool age, will suffer severe physical punishment or psychological violence from their parents or caregivers. And the numbers around the world for sexual abuse as a child are kind of are crazy. So there's a gender disparity. Women tend to suffer this type of abuse more often. So 1 in 5 women around the world versus 1 in 13 men around the world. But those are still staggeringly large numbers everywhere. There's a large number of kind of homicide deaths amongst children. And depending on how you calculate the number, there can be upwards of 1 billion children exposed to violence every year. So those are really, really big, scary numbers, but the world's a big, scary place. So how does Canada fare? And unfortunately, not that well. So these are some stats from a couple years ago, but there were over 60,000 child and youth victims for police-reported violence in Canada. And we know that police reports underestimate the amount of violence that happens because not every incident gets reported to police. And actually, the vast majority of, especially cases of sexual abuse and other types of abuse, don't get reported to police. So as you see kind of on the screen, there's up to like over 90% of child maltreatment cases may not be brought to police or to child welfare. So of the ones that do, there's still over 60,000 cases in Canada, more physical abuse, and of those, women and like girls and boys tend to be equally affected, but the sexual abuse is again disproportionately affecting females, but men are still, or males are still at risk. This one is a very interesting study. So this was a study that was done, I believe, by a researcher from Winnipeg, but I'm not totally sure, where they asked adults to kind of reflect back on their childhood and talk about what experiences they might have had. And so these are self-report, and this is a self-reported violence, but they said 32% of respondents said that they had suffered some sort of type of child maltreatment. A quarter of the respondents said they suffered physical abuse, and 10% suffered sexual abuse. And so this is kind of what this breakdown looks like. It's a kind of a shocking number, but they kind of break the physical abuse down into a couple different categories. So some might be less severe, but so slapping on the face, head, ears, hit, or spanked. So those are sometimes be considered kind of corporal punishment, or at least corporal punishment adjacent. But then there are more significant numbers of kids that were affected for kind of more severe cases. So there are also kids who were affected by the more severe cases, like kicked, bit, punched, choked, burned, more significant injuries. So those are kind of where we pull those numbers from. It's a pretty shocking. And you'll also notice that there's some overlap. So many of the children would suffer multiple types of abuse, not just a single type. Just a little bit more details on kind of sexual violence in Canada. So just to show that it's not just one study, it's multiple, like the same numbers kind of come up from multiple studies. So again, 1 in 5 women in Canada say that they were victimized as children, and nearly 1 in 10 of men report this. And you'll also notice that, again, older statistics, but almost half of all of the police reported sexual assaults in Canada were in children under the age of 17, and a quarter of them were under the age of 13. So this is a very significant problem for the country. Luckily, we have some resources. So this is a important resource to be aware of, I think, for everybody. This is a nonprofit organization run out of Winnipeg that publishes a lot of really important material. So I don't know if you guys are familiar with this, but I would certainly recommend looking them up. And so I put the website up there on top. They have all sorts of resources available. Some of them are paid, some of them are free, but they're geared to all sorts of different populations. So they can be, there could be for teachers and school-based learning. There can be for parents. There can be for the children of the teens, kind of broken up by age group. And there's some stuff that I've even used and brought in to use as part of my clinic. So some handouts and things to give out as a medical professional. So I would certainly recommend looking these guys up because they have excellent resources that you guys may want to have access to and review. They also manage the cyber tip hotline for kind of child pornography, and they actually they run a bit of a program that helps try to scrub some of these images from the internet. And they did release a report back in 2016 that showed that there are over 40,000 unique images and videos of child sexual abuse or exploitation online, I believe kind of from Canada, and most of this actually depicted prepubertal children and was kind of, at least half of it was quite traumatizing and actual kind of sexual contact, explicit sexual activity. There were a couple papers done a number of years ago now that tried to compare province to province. And part of the problem is that there aren't necessarily standard definitions, or the data isn't recorded in a standard way. So this was an attempt to kind of compare statistics about child maltreatment cases and presentations amongst the provinces of Canada. There were only 5 that participated, and luckily Saskatchewan was among them. So we have a little bit of data from that, so we can kind of compare. But it would be really nice to see a study like this redone and kind of include more provinces and territories to get a better sense of how Canada is doing nowadays. So the Saskatchewan specific paper certainly doesn't suggest that Saskatchewan's doing better than Canada in general. We actually have a higher rate than Canada would at baseline by a little bit. The majority of our cases were neglect, but there were all sorts of reports that came out, and there were some kind of demographic, like some kind of outcome differences that may be a reflection of the system, maybe a reflection of our history, but there was a much higher chance when there was a file opened or when there was a report made that a child would actually be changed homes in Saskatchewan compared to the overall rate in Canada. And so I think that's important for us to reflect back on, especially in the context of the 60s scoop and a lot of the social context that brought us to where we are now. There also was a disproportionate amount of kind of Indigenous children represented in these cases. And there are some statistics, depending on the studies, that show that overall, Indigenous children and adolescents are at higher risk of being sexually abused, with at least one estimate up to between 25 to 50%. Now, the last thing I want to do is suggest that this is a problem that is specifically tied to one population. Abuse can happen to anybody and from any background. And it's also really important to recognize that in order for something to be registered like this and to get reported and to be followed up on and to be investigated, somebody needs to see something, somebody needs to have concerns, somebody needs to report that to Child and Family Services, which means it needs to be screened in, and then somebody needs to go meet with that family and make some effort and some plan. And at any point, our preconceived biases can kind of step in there and break that chain. So sometimes I wonder if there's a lot of underreporting of abuse in situations where we don't expect there to be abuse based on our traditional or our kind of risk factors that we're often taught. That said, it is really important to recognize that Indigenous children of our province are disproportionately affected by this in the same way that many Indigenous people are disproportionately affected with negative health outcomes. So this is something that needs to be improved on for our province, kind of for the health and safety of everybody, but especially for our Indigenous families. We're unfortunately not going to be able to get through a whole hour or hour and a half without kind of addressing the big COVID elephant in the room. And I just want to talk quickly about kind of the pandemic paradox. So as we're all aware, many measures were needed to be taken to kind of protect the population from the COVID-19 virus and the spreading of this virus. And many of those things, many of those actions that were necessary may have placed children and families at kind of increased risk or increased vulnerability. And so that happened for a number of different reasons. So often there was a lot more financial strain, a lot of financial hardship. People may have lost their jobs, which increases stress and tension in the home. Children weren't going to school, and the vast majority of cases, or a huge number of cases that get reported, actually get reported through schools. There wasn't as many other eyes on these children otherwise, so they weren't seeing medical professionals, they weren't going out and doing activities, they weren't, there was a lot of virtual check-ins, and as you can imagine, it's not typically the caregivers who might be maltreating the children who are reporting on themselves, it's usually somebody else. So a family member or somebody in the community or somebody who sees children has a concern. And so obviously with that decreased amount of the contact, that there was less of that was happening. And you can imagine there was a lot of stress going around. We all felt it. And so those increased levels of stress can often translate into worse outcomes for the children. So going into the pandemic, there was kind of a sense of it's going to be bad. It's going to be bad for kids. And we weren't sure what exactly to expect. But the truth is these aren't entirely unprecedented. So we actually know that child maltreatment and child abuse increases during periods where children are kind of not observed or away from school. So it increases during school holidays and summer breaks. Many believe it's just because parents may not have that break away from their kids to send them into school. But also kind of in the recession back in 2008, there was an actual big increase in the number of, there was a decreased number of cases. So we actually didn't see as many things reported, but there were other kind of concerning signs that made us think that there was not maybe less, but perhaps more injury that was happening as those financial hard times hit. And in that time period, there was an increased amount of kind of severe head injuries to infants. So going into the pandemic, there was a lot of apprehension and concern about how things were going to turn out. And what actually happened, I don't think was terribly surprising initially, but it was kind of interesting to see in action. So this is actually a paper from some of my mentors in Toronto, and they kind of document the level or the number of cases that they were seeing during the pandemic, pre and post kind of shutdown. But really what was seen around the world is that there was a sudden decrease in the amount of reports to child maltreatment and to child and family services. So all around the world, kids were stopped, they weren't going to school, they weren't seeing other people. Suddenly there was a decreased amount of reports. But some of those places did see kind of increased numbers of children reaching out to child helplines or other things like that. So the kind of belief and the assumption is that probably maltreatment wasn't going down in those cases. It just wasn't being recognized and wasn't being seen if there was no one having kind of eyes on these kids, which is quite worrisome. And they actually kind of showed that overall, for all reasons, kids showing up to the emergency department went down in the pandemic. There were fewer people going into the hospital, but the proportion of kids that were coming in for maltreatment causes actually didn't go down. And so maybe the absolute number of kids coming into for this assessment went down, but when you compare to all the kids that were coming in, that rate actually increased. And the number of kids that needed admission didn't go down, meaning the kids that were severely injured enough actually were admitted just as were admitted just as often, or an overall percentage increase compared to all the other cases. It's a bit confusing, but that's all to really say that it doesn't really seem like the abuse went down. And if anything, the children who were maltreated may have suffered more severely during the kind of COVID-19 pandemic. And I don't know if any of you guys saw this when it circulated back in January, but it certainly was in keeping with what I noticed here in Saskatoon and many other centers noticed across Canada, is that there was initially this drop, but then once the fall hit, there was a massive influx of cases and a huge spike of very severe child maltreatment case, like presentations, that it was actually quite hard to keep up with. And this was kind of a bit of a plea from one of the pediatricians who does child maltreatment pediatrics in Ottawa, saying that this was the most head injuries and severe injuries in infants that she had ever seen, and that it was a plea to families to kind of seek help and look for support when you felt that you needed it. So it wasn't universal, it wasn't seen everywhere across Canada, but I certainly saw it here, and there was other centers in Canada where it really just exploded once the fall hit. And this seems a bit of a no-brainer, kind of why is maltreatment bad? But in addition to the obvious physical effects of maltreatment, there's a lot of mental health sequelae that come from being maltreated or being abused. And so there can be all sorts of, like, all traumatic experience can kind of disrupt normal child development. And so this is a very significant traumatic experience that can do that. But actually all types of maltreatment and physical abuse were associated with a whole whack load you'll kind of see on the screen, but basically every mental condition. And that wasn't stuck with just the most severe types. So even there was still a strong correlation with any children who had had any physical abuse, including spanking, kind of a bit of slapping or ear pulling, things like that. So what many families, this is not what I'm saying, but what many families would say kind of is normal discipline actually has a very significant mental health kind of impact. So we'll kind of touch on it a little bit in the future, but obviously as a pediatrician, I don't support any type of kind of corporal punishment. I don't think it's effective, and and it's not good. And this is kind of some evidence to support that there are significant mental health impacts from it. So to talk about the roles in the system, because sometimes this is a big source of questions that come up, I've drawn a bit of a diagram. So I kind of think about, there's kind of three main big areas. So there's myself. So I am the kind of that medical team in the bottom left-hand corner, and we all, like, from all medical professionals, are part of the medical team, but specifically child maltreatment pediatrics has a role in objectively assessing for injury and trying to medically describe why there may or may not be an injury. We'll talk about what specifically the role is later, but it's really about objectively describing and interpreting those injuries. Child protection services, their role is to ensure that the child is safe. And so it's their job to make sure that the living arrangement is acceptable and safe. And police and RCMP are really into, their role is to investigate whether or not a crime has been committed and whether charges should be laid. There's obviously other kind of not less important, but kind of often come in after. And so that would be kind of the mental health support. So definitely not less important than what I do, but needs to be done on a more longitudinal basis kind of for a long time afterwards. Police can then also connect the families with victim services, and ultimately, if necessary, the justice system gets involved, and potentially things go to court. So altogether, this makes the multidisciplinary team, and everyone has their own very specific roles in the system. So I touched a little on this, but so again, the child protection team, so this is kind of social services, their job is to ask the questions: is the child safe? How do we keep them safe? And are there other children that need protection? So together with police, it is their job to talk to children. They not every worker, but obviously the ones doing this job will have specific training on how to ask these questions appropriately to children and not kind of contaminate that interview and not to kind of plant new ideas. They're the ones who have to decide where guardianship of the child is going to lay and who is going to have access to that. And it's really important to recognize that although we may feel differently or we may disagree sometimes with decisions that are made, that is ultimately where it lies. So me as a medical professional or all of you guys, it's really not our role to decide what is appropriate, what's not. That is up to child and family services here, child protection services. Their decisions always get made basically, they make it on a balance of probabilities. They have to decide what is reasonably the most likely safe outcome. So generally, what is more likely to have happened, kind of greater than 50%. But it is a really, really tricky situation to be in, because there's harm no matter what you do if you're wrong. And if you don't nail it exactly right, over intervening and kind of separating families is traumatic, but under intervening and leaving children in a vulnerable position or open to kind of more abuse is also problematic. And even if the right situation or the right thing to do is to separate those families, there still is going to be trauma there. So it's a really difficult position for child and family services to be in. And I think it's also really important for us to recognize the social context that we have here in Canada, and especially here in Saskatchewan, especially reflecting on the number of cases that are involving Indigenous children, recognizing that Indigenous children are vastly overrepresented in our kind of child welfare system and in foster care. That all plays into these decisions and makes things so much more complex. From a law enforcement and justice system perspective, like I said, their job is to focus on, has a crime been committed and by whom? And it's really their job to figure out whether there are criminal acts and to decide if they can lay charges. But the difference here is that they need to be able to lay charges. They need to be able to reasonably have a chance of getting a conviction beyond a reasonable doubt. So they don't want to lay charges if there's some doubt or some question. So there's many, many situations where there may not be enough kind of proof to take something to court and to press charges, but there still is a large role for child and family services to put a safety plan in place for this family or to change care or guardianship. In terms of, this is kind of me or the CFMS team. So this is kind of what my job is in a nutshell. I want to walk through what kind of injuries there are. And so understanding if something's presenting, is it an injury at all? Or maybe it's not. So it might be a mimic, it might be something else. And then we also want to take a good look to see if there are any other injuries on the body. So it's kind of, sometimes we recognize that if a child has one type of injury, we want to make sure that there's nothing else. So it's my job to kind of make sure we've ruled everything else out, or we identify the injuries that exist. Then we have to ask the question of, is there a medical reason why these findings exist? So does this child have a medical condition that would make them bleed or bruise more easily? Or do they have a medical condition that would make their bones break more easily? Those types of things. Then it's really important. So if we've come to the decision that no, we think that it was actually trauma that caused this, or some sort of injury, could it have been from an accident? So what stories have been provided? Do they make sense? Could it possibly have been an accident that caused these injuries? And if that's not plausible, or we don't have a plausible explanation, that kind of leaves us with the possibility that this was an inflicted injury. So I need to kind of walk through all those steps kind of carefully to figure out how worried we are about inflicted injury. It's really important. We're extra careful about documenting everything objectively and interpreting really based on what we see. And so I don't take into account how families act or what they do or how they make me feel. Is really objectively about what we can see and what's been said and what can be observed and what we know from the medical evidence. It's my job to make sure that I can pass that information off to the appropriate investigators, and then they will make the decisions with that information as is appropriate in the case. And sometimes, most of the time not, but sometimes I'll end up having to testify in court as a medical expert. So that's kind of down the line. Very few cases ultimately go to court when given the total number that we see, but the more significant ones, we often do end up there, and I'll provide some expert testimony. So sometimes people have a general sense of what child maltreatment pediatrics is going to be able to do, and so I'd like to drive home the stuff that we don't do. So it's never our role to figure out the mystery, to solve it, to assign guilt, to point fingers. My job is to try to figure out if there's a concern, like how concerned are we in general that somebody might have caused this to a child. Never try to point fingers or figure out who. I don't get to decide what is safe for the family. I don't get to decide who can see the child or who gets guardianship or anything like that. It isn't my job to even talk to the children about what happened because I don't have that forensic training to make sure that I can't contaminate that interview. So I can ask very general medical questions, but ideally these children will already have been interviewed before they come to see me, so that the police and child and family services have all the information they need and they can share that with me. When the children are older, there's a little bit more wiggle room for asking some questions without affecting kind of the integrity of their interview. But as a general rule, I don't interview the children about their own experience. The interesting thing is, in Canada at least, I also don't decide if a child was abused. So that is a determination made by court or made by child and family services. I talk about the risk of an injury being inflicted. So how concerned am I that somebody caused this injury in the child? In the United States, it's a bit different. They do actually diagnose abuse, but it's a bit of a philosophical difference. We don't generally do that as child maltreatment pediatricians in Canada. And although therapy is really, really important to children and families, it's not generally me. That is our mental health care colleagues who do a great job with that and have to do that for a long time, but I don't have any specific training in that. And I like to draw, this is another little diagram I drew up. This is really how I think about my job. And this is kind of everything I do. And so every case that I'm going to see is going to fall on this spectrum. So either like on one end, I am not concerned for inflicted injury because it's either a very common accidental injury or it's not even an injury at all, or it's clearly a medical mimic. Or on the opposite end, I'm extremely concerned for inflicted injury. Really, I'm open to hearing new suggestions, but there really aren't. I don't know of a plausible accidental mechanism that might explain all of these injuries. So everything is going to fall on that spectrum, and it's my job to make sure that I can figure out where I fall on that spectrum by doing the appropriate tests and knowing the medical literature, and then communicating that to police or to child and family services, so they also get to that exact same level on that spectrum of concern. So that's generally how I conceptualize my job, and it's actually pretty easy when you fall on the ends of each one of those spectrums. That's a really easy thing to explain. But when you fall somewhere in the middle, that is where it becomes a lot trickier to communicate. And that's where there can be pitfalls and difficulties. An important concept I just want to also drive home is that child maltreatment is not a diagnosis. So I don't diagnose people with abuse or child maltreatment. It's a possible mechanism by which, through which the injuries might have been caused. And there is no injury that I see, and I know with 100% certainty that that was caused by abuse. That there are no injuries that are pathognomonic for child maltreatment. If you imagine, injuries can happen all sorts of different ways and all sorts of different accidental mechanisms. And so if something happens to a child by accident that that replicates the same way that we think an inflicted injury happens, it could cause these types of injuries. However, there are certain injuries that are very difficult to happen accidentally, and I would want a very clear explanation from an accidental perspective of how exactly that happened before I'd be ready to accept that. So although there's nothing that's 100%, there are things that are very, very concerning, and I would want a very good, clear explanation. And there are a few, that it's kind of also true with sexual abuse, although there is a handful of things that do actually diagnose sexual contact, but they're rare. So child maltreatment pediatrics, I see a bunch of different things. So physical injuries, sexual abuse, neglect, caregiver fabricated illness you may have heard about before. That's previously known as Munchausen syndrome by proxy. Sometimes goes by the name of medical child abuse, but that's basically when we're concerned that either an illness doesn't actually exist, so it's reported by caregivers and doesn't actually exist, or could even be caused by the parents to kind of mimic illness or induce illness to kind of seek medical treatments for a number of different reasons. Also kind of well within my scope is whenever people have questions or concerns, they don't know what to do, I'm happy to hear about it on the phone and talk through, hey, you know what, I think this does sound like this needs to be reported to Child and Family Services, or, oh, maybe you could do these steps first. Those types of questions I can certainly help people with. So now this all kind of boils down to what is your role as kind of people who interact with children and families. And I know that there's a diverse crowd here. So I've kind of focused on, this is what I expect everybody to know, and I'm going to help you guys do a little bit better. But basically for everybody, it's everyone's role to recognize when there's some amount of concern for child maltreatment. So knowing something about the red flags, and then knowing what to do with that. And we'll get to kind of duty to report in a bit, but basically everyone is responsible for calling Child and Family Services to notify them when they have a concern. So when exactly should we be worried? So there's a number of, again, we said there's a number of different types of maltreatment. And I'm going to try to focus on the ones that'll be more relevant to you guys. So we're generally not kind of primary healthcare workers here, so we're probably not getting seeing things like the fractures, the burns, head injuries, abdominal injuries. So I'm going to focus more on the things that will be more likely to come up to you guys as like a general kind of outpatient, interacting with families, kind of living at home kind of basis. Overall, though, really it comes down to this fundamental question, no matter what type of kind of physical injury we're talking about, is really, does this make sense? And that's the question I have to keep asking myself every time I think through something. So does whatever injury they're seeing, does it make sense with the story that's been provided? Does it make sense with what this kid is actually capable of doing? Like if I've been told that the kid rolled off a table and fell down to the ground, can the kid roll? Like, what does that look like? How did this appear? Like, what did the kid look like afterwards? Does the picture kind of fit? So these are kind of the ones that I'm going to break down a little bit more here in the presentation, because these are the ones that I think you guys are likely to come across at some point and could potentially activate the system from. Less likely that you're going to be the first point of contact for these other injuries. So a really important concept here is the Sentinel injury. And it's a relatively recent term, but the idea is that sometimes there are really small, we'd say minor, negligible injuries in a little infant or a young baby that doesn't seem like a lot, but actually has a profound kind of importance. So generally speaking, and depending on how pedantic you want to be with the definitions, it's usually talking about bruises in a non-mobile infant. So a child before they're able to kind of crawl or move themselves around or pull to stand, bruises or intraoral injuries or bleeding from that. There are some papers that kind of looked at these injuries and found that children who later presented with very significant inflicted injuries like fractures or head injuries or death actually had previously been seen by medical professionals with more minor injuries that were kind of brushed under the rug or swept under the rug or not really given the importance that they meant to. So the idea is that these sentinel injuries, we should be on high alert for them. They're not normal, so we should understand where they came from, because whatever situation led to this infant getting this more minor injury, if it's not addressed and corrected, could result in escalating violence or increased violence and a more significant injury later. And I have unfortunately seen many, many kids come in either severely injured or dead after reviewing. Kind of when I look back through the medical record, I see that these children have presented before and it was just ignored or not properly interpreted. So these are really, really important, this really important concept of, even if it doesn't seem like a big deal, it's a big deal. So what are common sentinel injuries? So this is taking a bit more of a broad definition of what sentinel injuries could be, but bruises for sure, especially in an infant that can't move. Subconjunctival hemorrhages, that's kind of burst blood vessels in the red part of the eye. It's important to recognize that that could be injury, but that could be a lot of different things. Even crying very hard could result in that kind of bleeding of the eyes. So it's definitely softer. Intraoral injuries, basically, and we'll talk a little bit more about that, but kind of any injury on the inside of the mouth is not normal in a young infant or young child. And then there's a nice pretty picture here of 10-4. I don't necessarily use this or teach this all the time, but it is a pretty it's a pretty good tool to use in terms of recognizing where normal bruising distribution is and where it's not. So again, the frenular injuries, so I've kind of said that before. So the frenulum, and you guys can do this at home. So the frenulum is, there's three in the mouth. It's a little band of tissue that connects the lip, the bottom lip to the gums, or the top lip to the gums, or the underside of the tongue to the base of the mouth or the gums. So if you could probably feel that yourself with your tongue, but there is those three bands of tissue. Generally speaking, those are pretty normal. You should have them, but they can be commonly injured in inflicted injury events. They're not, before the kid's mobile, it's not very common to happen accidentally. So any kind of direct or shearing trauma to the lips or to the mouth can rip or tear that and cause some bleeding. And the most common time we see that is with kind of force feeding, where parents are frustrated and the baby won't take the bottle and the baby keeps crying, and it actually kind of gets forcefully fed or moved around the mouth, and that can disrupt those frenula. So that's the most common way that we see injuries. You can see them even in older kids, other oral injuries in older kids who are being forcefully spoon fed or other things like that. But it is really important to recognize that that becomes a little bit less of a concerning feature when the kids get older. So as soon as a kid is up and running around and walking and they can fall and smash their face in the ground, a torn frenulum or a bleeding from the mouth is not that big of a deal. But the kids who are pre-mobile should not be having that problem. One thing to keep in mind for the babies who have moved, though, is, and I don't think this will come up as much for you guys unless you're doing a physical exam of the mouth, which most of you would not, but you've probably heard of tongue tie clipping before, and that's a whole thing to talk about on its own, which it won't even touch, but that's kind of cutting the frenulum underneath the tongue with some people think it helps with feeding and speech. And there's also now lip tie clipping, which is a bit newer. So it's possible that one of those could have been surgically cut in the past. So it's important for us to know that as medical professionals if we're figuring out why there's an injury there. But it is an important kind of context if any of you guys are doing a first kind of an oral examination of these children. The big take-home point I want to take for you guys to take from this, though, is bleeding from the mouth in an infant is not normal. There's many times where I kind of hear about this after the fact or hear about afterwards. There's an explanation of, oh, well, this baby bit their tongue or they did this, and that's where this blood is coming from. And that is not an adequate explanation. We really need to understand why is there blood there, and I would not accept that as a reasonable explanation. So bruises is a kind of another common thing you guys are going to see. And the most common reason for kids to have bruises is trauma. As we know, we've all bumped or hit ourselves. So we all know what kind of bruises feel like and look like on our bodies. But it's important to recognize that person to person, they're going to look different. They're going to resolve differently. And we know that bruises could happen from accidents, falling, bumping yourself, but it can also happen from an inflicted injury event. So somebody causing that injury in the child. But there are also many, many medical causes. And so that's part of my job, is to work through making sure that we know, is this a bruise? So ruling out mimics, which can sometimes, birthmarks can be confused or rashes can be confused. I've seen people, either kids draw on themselves or parents draw on their kids to try to fool people into thinking they're bruises. So we want to make sure that they are bruises, and then we want to rule out that there's no medical reason why this child would bruise or bleed more easily than another child. That doesn't, so just because a kid has a medical condition that causes them to bleed doesn't mean they can also be abused. So it does become a bit tricky to tease those types of situations apart. Luckily, the vast majority of people don't have any medical problems that contribute or cause bleeding. So these are the kind of the bruising red flags I want you guys to take home with you. So important to kind of recognize is the parts that are kind of normal bruising. And some of this is going to be very intuitive to everyone here, just from being a human and having suffered these themselves or having kids. Bruises are really, really common in kind of areas where there's basically a very thin layer of skin in between the bone and the outside world. And so any little bump or hit or something like that can squish that skin, kind of break those blood vessels and cause a bit of a bruise. So really, really common places in kids and even in adults is kind of forehead, the nose, kind of this T distribution, the cheekbones, even the jaw. And then kind of forearms, elbows, knees, shins. If you just imagine on the body, anywhere where you can feel and it's hard because there's bone underneath, that's pretty easy to sustain a bruise kind of accidentally. So it's pretty normal to have 1, 2, and even lots of those bruises on knees and shins, especially as children are starting to walk and to move. So those are kind of the normal bruises. Bruises that are not normal are, because they're so much harder to get, are bruises on kind of soft, flexible, or padded areas of the body, because those either with fat or with muscle or with skin kind of absorb that blow or that impact much more easily than these other areas with the thin skin. So we're talking about things like the abdomen or the buttocks or the genitals, the inner thighs, the ears. So if it's a soft, squishy, flexible part of the body, it's way harder for that to be induced accidentally, and even very significant traumas often leave no injury or no mark. So if we're seeing bruises of the belly or we're seeing bruises on the buttocks, that makes me worried about the amount of force that happened. It's very rare for accidental. It's not impossible, but it's very rare for accidental impacts to cause those types of bruises. Similarly, most kids will fall forwards. So most of the time kids will fall, and so they're accidental bruises on the front part of their bodies, but that doesn't mean it's impossible to have bruises on the backside, especially if there's a history of falling backwards and you can feel on your own back, there's generally some bony prominences and some kind of thin skin overlying that center part at the very least, that could easily bruise. So it's not impossible that bruises happen on the back, they're just less common. And so you kind of have to think about how exactly that bruise might have happened. And sometimes we just don't know, and we have to kind of, sometimes we're left with a bit of uncertainty. And so often in that case, you're kind of raising the question to somebody or potentially making a report to clarify that might make sense. Most of the time, bruises are discrete or individual, so they're not, you don't there's kind of maybe one here, maybe one or two kind of close by on the lower legs, things like that. And they're usually small. There's not a really good sense of exactly what that means. It's usually a centimeter or two or a couple centimeters. Once you're getting kind of 3, 4, 5 centimeters, those are bigger bruises. So I'd kind of want to have a better sense of where or when that might have happened. So if they're pretty big or there's a lot of them, and so sometimes you just see there are so many bruises on this kid, I don't really understand, like a couple are pretty normal, but this is a lot. And so sometimes that's a bit of a judgment call. And really, really important is this idea of bruises shouldn't be patterned. So I consider things to be a pattern if it's not kind of a circle or an oval or kind of an irregular shape. If there's straight lines or multiple repetitive lines or patterns, sometimes you can get like cross hatches or funny things if kids are ever hit with objects. And really, really important is if there's ever marks or bruises. So it can be bruises or sometimes even residual skin marks that look like loops or C's or things like that, are often kind of impact with a belt or impact with a cord. So really, really common now is people getting hit with phone cords. And so if you see any funny shape that doesn't look like your regular oval bruise, that kind of raises question of, okay, where did that bruise come from? Why is it there? And then the last point I have on the slide really just comes back to the concern, or what I said, the fundamental principle is, does it make sense? And if there's something about it that doesn't make sense to you, then maybe you should be worried. This is more of a frustration. I think it's good for everyone to have for your knowledge, but this is more of a frustration on the behalf of Child and Family Service and police. They often want me to tell them how old a bruise is by looking at it. And so many people will describe bruises as being old or new or fresh. And the truth is there's way too many pitfalls for us to be able to reliably look at that. So, and to say anything about that. So they've looked at studies and they see that different people, depending on their skin tones, will resolve bruises in different timeframes, in different orders, and the bruises will look different. And even bruises within the same person will resolve at different rates in different ways. So although previous teachings from a decade or two ago would have said, yeah, this is what color bruises are at these stages, that's not true anymore, and I wouldn't hang my hat on it. So I look at bruises and talk about dating in terms of when was the last time someone saw them without that bruise. And so I don't expect a bruise to kind of something to happen, there'd be an extended period of time and then a bruise to appear. The bruises happen pretty quickly after. There's not a kind of a delayed presentation. So I wanted to talk a bit about kind of corporeal punishment, and I mentioned it briefly earlier, but I think it's important for us to recognize what the law is here in Canada. This is not an endorsement of the law by any means. I am not saying that this is what I think it should be, but I think it's important that we all recognize what is the law to be able to interpret what is reportable and what is not. So in the Criminal Code of Canada, Section 43, so this is the one specifically addressing corporeal punishment in children, it's voiced as every school teacher, parent, or person standing in the place of a parent is justified in using force by way of correction toward a pupil or child, as the case may be, who is under his care, if the force does not exceed what is reasonable under the circumstances. That's what the law says. Is that a particularly well-written law? Is that a particularly clear or informative law? Not really, because it leaves a lot of questions open to interpretation. And actually, in 2004, there was a court kind of case challenging that, where they wanted to basically remove that, remove it from there as a violation of children's rights. And actually, it did not pass. So 6 of the 9 judges said that this law did not violate the Canadian Charter of Rights and Freedoms towards the children for a number of different reasons. So they said it didn't infringe on a child's right to security, didn't infringe on a child's right to equality, and did not constitute cruel and unusual treatment or punishment. So ultimately, it was upheld. They did add a few kind of clarifying points, which I think are important to recognize. So they talk about by way of correction, which means that it needs to be in a child that can understand that it's meant to be punishing, and it has to be directly connected to the event. So you can't Someone can't hold it later and plan to punish them later. You can't do it in a child who's too young, so not under the age of 2, or if they're developmentally not kind of able to understand that, you can't use physical punishment. And the idea is that it is meant to teach the child. So if the child cannot learn from it, then it's not lawful and doesn't fall within this from this law. It also has to be sober and reasoned, whatever that means. So there's some variety in there about what exactly is reasonable. Generally, you're not like sober and reasoned would not kind of include leaving physical marks or leaving bruises on the child. That seems like excessive force application. Reasonable under the circumstances, talk about the force needing to be transient or transitory and trifling. So again, it's not a significant force application. You're not trying to harm the child, and it can't kind of bring them shame or denigrate. So you're not actually allowed to hit teenagers. You can't use objects, and you can't hit the head. So there are some clear caveats guidelines from this ruling in 2004, but overall, it's still a little bit confusing about what exactly is allowed and not allowed by Canadian law. Importantly, though, they did take out, although the law still says school teachers, they don't say that teachers have this ability anymore. So a teacher cannot strike a child by means of correction. So it's improved, but it's still present. And I think you guys all need to know what the law is before we go and report every possible bit of kind of physical discipline that we see. So again, this is not me endorsing the law. This is not me saying as a pediatrician, this is the right law to have. And it's not me saying that there certainly are negative health impacts to physical punishment. And to my knowledge, there are no studies that support that it is actually effective or helpful, but that is where the law stands. So shifting gears to look at child sexual abuse a bit. Again, there's a lot of different ways of looking at it, a lot of different definitions, but here's the one from the WHO. So it's basically the involvement of a child or an adolescent in any sexual activity that he or she doesn't understand or is unable to give consent to, is not developmentally prepared for, which kind of ties into that previous point, and violates the laws and taboos of society. Again, presumably, that's illegal forms of sexual activity. And then the Saskatoon Child Abuse Protocol we'll talk about a little bit later, but that's kind of the definition they have about sexual abuse. So has been or likely to be exposed to harmful interaction for a sexual purpose by a parent, caretaker, or any person in a position of trust and or any other person. So again, there's a wide variety of what that might look like, but different forms that could take. And it's important to recognize that it doesn't have to involve physical contact. So non-physical contact, but sexual exposure or things that people are said or other things like that can also be sexual abuse, even if there's no physical contact that happens. And I would argue that sexual abuse is always emotionally abusive. There's an underlying emotional abuse to it because there's a betrayal of trust. We are meant to kind of safeguard our children and take care of our children. And so any kind of abdication of that and a kind of transgression against that is a betrayal of the trust from the child towards the caregiver. So I think similar to talking about the law in corporal punishment, I think it's really important for us to understand the law when it comes to consent. So consent is basically your voluntary agreement to engage in sexual activity, but there can never be consent if someone says or does something that shows they're not consenting to an activity. So if you say no, it means no. And it doesn't have to be with words. It can be other ways of showing that you're not interested in sexual activity. So you can also revoke your consent. So you can agree to do something and then change your mind or not consent to something else that happens. So if you do something to show you're not agreeing to continue an activity that has already started, you cannot consent if you are intoxicated or unconscious, which is a big one. And you can never consent, even if the child thinks they're consenting, you can never consent as a result of someone abusing a position of trust, power, or authority. and you can't grant consent on somebody else's behalf. So what can people consent to? So what is the actual age of consent in Canada? So unfortunately, it too is not a very simple question. So the official age of consent in Canada is 16 years. However, there are some caveats. So that 16-year-old can't consent to pornography, prostitution, and you can't have a relationship with somebody of authority or trust or dependency. It can never be done. So if you think back to that other slide, it can never be done if there's an abuse of that authority, but it just strictly not be done at all if there's that authority or that relationship exists until you're 18. And then once you're 18, you can consent to the above things. However, kids under the age of 16 can also consent to sex within certain limits. And so those are the close in age exceptions. So a 14 or 15-year-old can consent to sexual activity with somebody up to 5 years older than them, so long as it doesn't violate any of those other kind of rules. So a 14-year-old could have sex with someone like less than 19, and then a 15-year-old could have sex with someone less than 20. And then a 12 or 13-year-old can consent to sexual activity with somebody who's less than 2 years older. So a 12 could consent to 14, and then a 13 could kind of consent to somebody 15 or younger. Under 12, at no point can someone provide consent. So there is a hard limit at the bottom, and then there's a lot of kind of gray zone that we sometimes need to tease apart. If someone discloses that they've had sex, to figure out, okay, who did you have sex with? Not necessarily names, numbers, things like that, but who was this person? How old are they? How do you know them? Those types of questions might need to be asked if this comes up. So sexual abuse concerns can come up for a number of different reasons, and I've kind of seen them all. And but these are all things that might show up to you or be presented to you, so you might need to be aware that this happens. So most commonly, especially in prepubertal children, it's something that the kid says. So a disclosure was made by the child. We know that a huge number of these kids don't disclose for a long time. They don't disclose because they don't feel safe. Sometimes they'll make small disclosures bit by bit, testing the waters to see how well it'll be received and whether they're going to get in trouble. So it's not uncommon for disclosures to evolve and change over time. So that's probably the most common reason. Another one we can talk about a bit later is kind of sexual behaviors by the child. So there's normal sexual behaviors and less normal sexual behaviors, and those can sometimes alert people and raise some concern. Lots of people become concerned because something looks wrong down there. So there's some sort of genital abnormality. Not saying that they can't be right, but the vast majority of the time, it's really just people not understanding what a normal genital anatomy should look like for a young girl. But it is something that often comes up, and I see kids a lot for. And then other things, obviously, if there's a genital problem or complaint, there's many things that can cause that, but one of the things is potentially sexual abuse. So pain, bleeding, discharge, those types of things. So any combination of these things might lead to a kid being a concern being raised for sexual abuse. And any of these might come up to you guys in your interactions with children and the families. So yeah, like I said, a delay in reporting is very, very common. And sometimes it's years and years later when the actual disclosures get made. And so that's part of the reason that the vast majority of the time, there aren't actually any physical exam findings. And I'll talk about that in just a few slides. We often always think about stranger danger and don't talk to strangers, and that's absolutely, like, it's an important message to teach children, but child sexual abuse is actually more common to happen from family members or acquaintances than it is from a stranger. So again, it's still pretty common for an acquaintance or a known person for adolescents and for teens and for older women, but especially for prepubertal kids, it's usually somebody that they know. And like I said, most of the exams, and this is true for boys, it's true for girls, it's true for prepubertal and postpubertal, the vast majority of the time, there's nothing to see on the exam. So the exam is non-specific or normal. And so very, very rarely do we see injuries. And if we think about it, or like when we think, we all have probably a preconceived idea of what sexual abuse is or what that might look like. And actually, child sexual abuse more typically doesn't, not saying that the more horrific kind of things that you think of couldn't happen to a kid, but often the sexual abuse is more in terms of fondling, or touching or exposures or things like that, which we wouldn't expect to necessarily cause an injury, but is still sexual abuse regardless. So again, this is a big take-home point. I tell this to everybody, especially my medical colleagues, but for everybody, I think this is really important to know. Vast majority of the time when I see patients, there's no findings is very normal, and that does not mean that nothing happened, and it does not mean that we do not believe the disclosures. So there's a lot of different reasons why that could be normal. So it's possible that there could have been something that happened to this kid that didn't cause any injury, and there's a lot of types of inappropriate sexual contact that may never cause injury, or there may not have been contact at all. Or if there was some sort of contact and there was an injury, it actually heals very, very quickly. And so just because it's healed and gone doesn't mean there was never anything there in the first place. And that ties back to the delay that so many people have in kind of presenting to care. Then, I mean, one of the possibilities is that it never happened. But again, I can never say that or not say that. All I can say is, do I see injury or not? If there's injury, I can interpret it. If there's no injury, I say, this doesn't tell me one way or the other whether or not abuse happened. And I would like to touch really quickly on this idea of virginity. This is a bit of a soapbox, and hopefully you guys can take some of this forward. But basically, we've been taught that virginity is this thing. It's part of your body. It's something that changes when you have sex, and all of that is complete BS. From a medical perspective and a scientific perspective, virginity does not exist. It's not a real thing. And you cannot tell if somebody has had sex before definitively just by doing a genital examination. So I've had patients brought in by their families before for virginity tests, and it's not a thing. It should never be done. It is not scientific, and it cannot rule out the possibility of kind of sexual contact in the future. I mean, if there's kind of injury or kind of healed injury, that might support that there's been some sort of sexual contact. But the idea that you can tell somebody is a virgin or not by doing a physical examination is nonsense. However, we have to recognize that this concept of virginity is often very important to families and very important to these people. And so it can be, you have to be kind of delicate when you address it. But I still, I would always refuse to kind of do an examination like this, kind of regardless of what the family's kind of feelings or what they want to be check. How I conceptualize it and how I explain it to the teens that I talk to is that virginity is something that we kind of, it's a social contract. It's something that we make up, and it's something that we kind of choose to believe in. And it's something that you can share with somebody when you choose to, if you choose to. And so it's not something that can ever be taken from you. It's not something that, so if you're ever sexually assaulted, no one can take your virginity. You're not a virgin anymore. It's not something you get to choose to share with somebody else. And it's also really important to recognize that you don't have to believe in it. You don't have, it's not something that's important. And it's not something that is scientifically real. So I try to encourage that, especially if there's a lot of concern about from the girls or boys, but usually girls or their families. I try to deconstruct this idea that although it's very deeply ingrained in us, it's just virginity doesn't exist. It's not real. Kind of finally, for sexualized behaviors, I want to kind of go through a couple charts because this is often something that's going to come up. I'm sure with many of you, you'll kind of either notice behaviors or behaviors will be reported to you that make you worried. So I just want to talk about things that are pretty normal, things that are less normal, because we know that kids, sexual exploration is a normal part of childhood development. So it would be abnormal to have no sexual exploration at all. Like we expect that. So it's really up to us, and it can be really, really tricky to tell between what's normal exploration and what's abnormal exploration, and when should we be worried? When does that tip the scales into needing to activate something else? Also, it's going to be really important to be able to reassure families that, you know what, I know what you're seeing is distressing, or you don't think it's normal, but this is actually fairly normal, and I don't think you should be worried about that. Sexualized behaviors start very shortly after birth, and kind of in infancy, and then they peak around age 5 or starting to school age. And then as people are taught, like it's really important to kind of teach children what's appropriate, what's not appropriate, what you do around people, what you don't do around other people. As people learn, as the children kind of learn those social rules, they tend to decrease over time. And then it becomes a more private thing. So I've got a couple charts here. This kind of, and there's going to be overlap between these charts because they kind of talk about the same sort of things, but this is important to kind of talk about how I think about these sexual behaviors. So there are some behaviors that are just pretty normal and don't really raise concern. So that's generally kind of a curiosity about sex, about their own bodies, about other people's bodies, and kind of touching themselves and making themselves feel good. That's very, very normal. And the important thing is, like, generally it's brief. You can kind of distract or stop a kid from doing it, and it doesn't happen very often. Then we start to get into behaviors that are a little less common, that are normal, and that's kind of more kind of physical contact things with others. So kind of rubbing your body against others, or trying to touch somebody else's genitals or an adult's genitals. And the behaviors can be kind of a little bit more persistent, but ultimately can kind of be deterred. And so it might be, yeah, so these are still, they're less common, but still pretty normal. And then there's then we start to stray into behaviors that are not very common in normal children. And then there's behaviors that are really kind of abnormal and make us worried. Okay, so I'm going to switch to another chart because it's kind of the same information, but that's generally how I think about it. Again, it's a very messy, blurry spectrum. And so trying to figure out exactly how worried we should be can be challenging. So again, common sexualized behaviors in young children include masturbation, touching your own genitals, or mother's breasts, showing your genitals to other children, or wanting to see other people's genitals. That's normal. And then older children kind of start to explore or have questions about sex, or want to do things. So showing interest in opposite sex or same sex, asking questions about sex, looking at photos, those types of things are actually pretty normal. And you can actually have even sexual play or sexual touching between same age peers. Not saying that you should allow it, but that could be still normal exploration. Concerning things, so these are the parts that start to raise red flags, that again, none of this means for sure a child's been abused, but maybe we need to start looking closer, asking, like getting somebody else involved so they can ask right questions and touch base with this kid. And so those things that make me worried are kind of, if a kid knows more about sex than we feel that they should. And that needs to be taken into with the caveat of, every time we're looking at something, we're looking through our adult lens. And so we look at behaviors of kids and what they're doing, and we say, oh, they're doing this because somebody has taught them this or someone has shown them this, whereas that may not be what's going through that kid's head at all. So just recognizing that we are looking at things through an adult lens, through our own kind of very sexualized existences, and that may not be what the child is actually role-playing or acting out, but there is going to be a certain amount that you'd expect a kid to know about sex. And so if they know very specific details, or describing other acts, or acting out other things that they really probably wouldn't know, that is a bit concerning. You want to understand, where did they learn that? Have they seen kind of pornography, or they've been exposed to sex, or whatever that was. So lots of that is also kind of more adult sex acts, like oral sex, or anal sex, or kind of even the mechanics of sex itself, depending on how old the kid is. And most important to me is the idea of that normal sexual exploration is kind of, it's there, it's a bit of an the kids are trying things out, they're seeing what works, and so they can be distracted and they can be taught and can be deferred, and it should be kind of normal and healthy and kind of not it should kind of feel good for the kids. So if it is distressing to the children, if it seems to cause them or somebody else pain, if the kids will not stop and cannot be deterred, then those things start to raise red flags to me. So if you can't easily kind of nudge them away or get them to something else, then that is a bit of a concern. And then finally, some non-specific behavioral changes. Here's a whole list of things that often come up as a question to me. Do you think this kid's been sexually abused? And the answer pretty much always is, I don't know, because really all of these behavior changes could happen with any sort of life stressor or reaction to anything. One of those things could be sexual abuse, but without an actual disclosure of sexual abuse, we can't assume that that's what's going on and causing all these problems. So perhaps if there's a bunch of behavioral dysregulation and a lot of these things are being seen, perhaps that's worthwhile having somebody sit down and talk to them about what's happening and what's going on to cause them to do that. But we can't assume that that just automatically means that they've been sexually abused. Talking quickly about types of neglect, there's a whole bunch of different types. This is probably not news to anyone. And so there's different, so really it's the caregiver's responsibility to be able to provide kind of food and shelter and access to medical care, supervision to keep them safe. So if any of those things you're not recognizing that could be neglect, recognizing that there is a huge interplay with kind of socioeconomic status and poverty and access to care and access to things like food and water. And then there's also kind of emotional types of abuse. So kind of not modeling of that appropriate caregiver responsibility and kind of nurturing and affection, or even kind of educational neglect if the kids aren't being provided the educational opportunities that they should be kind of by law. And then this is a slide I kind of like to include more for the medical crowd. We'll kind of skim over it, but basically when I have to go, it's a bit of a complicated procedure to decide if somebody's been medically neglected. We may feel differently. We may feel that a caregiver is not making the right decisions on behalf of their child, but there's a very prescribed checklist that we have to go through to make sure to say, you know what, actually this constitutes medical neglect, as opposed to the parents just have a different opinion from the medical team about what should happen and what should be going on. So finally, the last section, and I took longer to get here than I was hoping, but the last section is a really important one. This is like what to do, when and how to report. So up until now has been kind of when should you be worried, and now it's what should you do. So there's a child abuse protocol. I believe there's a new one coming out soon. I don't know if it's a 2021 or if it's going to be 2022, but this kind of outlines all the different roles. So the medical role, the child and family services role, the police role, and the public role about what we should be doing when we're concerned for child abuse. And the really important thing to take home is the duty to report is not just a professional one. It is not just for professionals interacting. It applies to every adult in this province. So actually every adult has the duty to report if they're concerned that a child is at risk of being harmed. So it says every person who has reasonable suspicion to believe that a child may be in need of protection shall report this information to a child protection worker, Ministry of Social Services, or an FNCFS agency, or a police officer. So that's a very specific and interesting thing for Saskatchewan, and I believe Manitoba, but nowhere else in Canada as far as I know. So we actually are allowed to report directly to a police officer, which is not the case in other jurisdictions. And I think that's to kind of help, especially in places where there isn't after hours child protection worker coverage, that gives them somebody to report this to. So your duty to report, so if you are concerned and you have a reasonable suspicion, then you must report to one of those people. I encourage you, if you're going to make a report, make it to Child and Family Services if possible. But if that is not possible, then you can contact police or RCMP. It's really important to recognize that your duty to report supersedes any concern for confidentiality or professional privilege. So you are not protected from a professional perspective just because you say, well, this was told to me in confidence, or I couldn't share that. This supersedes that need for confidentiality, so long as the report you're making is made in good faith. So obviously you're not able to just report whoever you want just to screw up their lives, but if you're truly believing that you're doing it in the best interest of the child, then you are protected from a professional perspective. If you're concerned about abuse, you should report it immediately. You shouldn't wait several days. You shouldn't try to figure this out. You should make that phone call. And even if you think that it has already been reported or you're not sure, and you think maybe somebody else is calling, you need to call yourself. It's a non-deferrable. If you have that concern, it's a non-deferrable duty. Realistically, not every member of the team needs to call, but somebody needs to call them who's having this concern. Even if you know that something's been reported in the past, if there's a new thing that comes up, you have an ongoing duty to report. So even if you know that something's been called, Child and Family Services had a file with the family, they've closed it since, every single time you have a concern, you need to pick up the phone and call them and make that report again. And sometimes that's what it's needed to kind of reopen a case and get a kid protected. It is possible to report it anonymously. You don't have to share your name, but I always recommend kind of sharing your name, and I always do myself. That's ultimately a decision you're going to have to make. And you don't need to tell the family you're reporting, and it's probably less of an important deal depending on who you are and your interactions with them kind of in the community. But I generally encourage anyone with an ongoing relationship with the family to let them know. But again, that's a personal decision, and I especially geared towards medical professionals, I say that it usually protects the relationship, the therapeutic relationship going forward, but that may not be the case for you. So you have to make a decision as well as whether or not you're going to tell the family ahead of time if you're going to make that phone call. What they're going to want to know is they're going to know who the kid is, who you are, and what your relationship is to the kid, and how do they possibly contact, who you are, what your relationship is, how do they contact you again, and then who is the kid, where are they, as much information as you can give. And then it's really important to explain to them, why are you worried? So what specifically is making you worried? And you may have more medical knowledge than the people that you're speaking to on the phone. So sometimes you need to break it down into very simple language. I am worried about this because. You also, if possible, want to give any address or phone numbers or names of parents or things like that. They always want to know things like, do you know the parents' birth dates and things like that, which of course you don't, and I don't expect you to, and I never do, but they so give them as much information as they want to know, and you can ask. But I wouldn't delay reporting just to try to gather more and more of this information. It's also important to recognize if there are any other kids at home, they're going to want to know, are there siblings, are there cousins, is there anybody else who might be at risk? And then these are the numbers that you guys should call. The main lines are here, so kind of north, center, and south. There's also likely local organizations. So I know there's a local one in North Battleford and other kind of centers. But the truth is, what you need to do is you need to pick up the phone and call one of these centers, and then they can sort out where that's supposed to go after the fact. So I would pick up the phone and call these numbers to report. You can also loop us in. We are kind of optional because if Child and Family Services wants to reach out to us, they certainly can. So we're calling me or the Child and Family Medical Services Clinic for advice does not necessarily absolve you of your duty to report. So we're happy to take phone calls about what should I do? Is this reportable? But many times we will say, yep, you need to now call your concern to Child and Family Services. So you can call us and we can talk through cases and we can potentially kind of arrange something if there's something directly you want to talk to us about, but that doesn't replace reporting to Child and Family Services. Regards to sharing information, the one thing I want to take with you is, because I don't know how much necessarily background training you guys have in kind of medical records and keeping. I certainly know as kind of physicians and nurses, we're drilled in, you can never share with police, don't share with police, don't share with police. And I'm here to tell you that that is actually also a lie. And at least in Saskatchewan, in the context of a child maltreatment investigation, you are actually, not only are you able to share information without consent that's pertaining to that investigation, you're actually legally required to provide it to the police. Again, we're always available to kind of talk through the nitty-gritty of the details about that, but it actually goes against what many of us were taught quite over and over in healthcare. That doesn't necessarily mean that applies in all other contexts, but when you're specifically talking about a child maltreatment investigation, you are required to share information if it's requested. my case, a lot of that is, yep, they can have that information, but you need to apply through medical records and get that in the same way that they would kind of get any other chart. But that means I can also talk to them on the phone and share the information with them directly, even if I don't have consent from the families. So unfortunately, I overtalked and I only have just under 10 minutes left for questions, but I'm happy to take any that are there.
Thank you, Dr. Weiler. There haven't been any questions put into the chat, but I have actually clicked it so that people could unmute themselves if they wanted to ask a question out loud. Or they can put their question into the chat, either to everyone, or I am actually listed as MI or motivational interviewing. If you send it to me, I could read it out loud. And yes, the Zoom recording will be made available. That's correct. You're okay with that, Dr. Weiler?
Yeah, that's totally correct. And I'll just flip through if you guys are interested in the resources. I've got a couple slides for references and stuff like that, just so that it's there in the presentation.
Great, thank you. So thank you very much. That was a lot of information, and you know, of course, some of it's difficult to hear. I was squirming at times, but it's very important. So we very much appreciate you taking the time to speak with us. And I'll just let people know that it could take up to a week or more before the recording is available on our website. So you're welcome to check in with us or just keep checking the website. Or you can email myself, Megan Clark, to ask when it will be posted.
Just going to double check one of the numbers that I had in my presentation because I want to make sure that it's actually the correct one.
It looks like someone has unmuted themselves. Stan, are you going to ask a question? Perhaps not. All right.
Okay.
Stan, did you have a question? Oh, you just unmuted yourself. Okay. Or you've muted yourself now. Okay. So it doesn't look like anyone else is going to be. Oh. No. Okay. I don't see any other questions coming in the chat. So maybe just give another minute or two. And if not, we will just. I'll go away to digest all the information that you have provided with us.
Yeah, it was definitely dense, and it's not an easy topic to hear or talk about, but I appreciate you guys sitting through. So
thank you. Yes.
Dr. Weiler, this is Kara. I'm the Child Injury Prevention Program Coordinator with this Prevention Institute. So just, is there anything, a statement or a tip in terms of prevention of child abuse that you would want to get across?
So that's always kind of that's the magic bullet we're all kind of looking for, is how to prevent it from starting in the first place. Unfortunately, a lot of what we have is reactive. I would argue that unfortunately, most of the things that we need to do to implement to decrease kind of physical abuse are bigger societal and systems changes. So making sure that there's kind of good parenting supports available to families, making sure that there's alternate kind of caregiver supports, and that every kid has access to food and to kind of financial security, and to all these kind of things that contribute to stressors in life. I think it is really important to teach children and families about kind of language. So understanding how to talk about their bodies and knowing the right words for talking about their bodies, and being able to kind of share those types of things so that they have the language they need to express themselves if something like this were to happen. So they need to know what kind of limits of confidentiality, or like the limits of consent are, what's appropriate, what's inappropriate, and they need to know that there's a safe place to be. So I mean, addressing those things is really important, having an environment where that's possible. But unfortunately, a lot of the factors that kind of lead to kids being maltreated are kind of the ones that are big social changes that the families are often don't have any support, and they don't have any relief, and they don't have any kind of skills to cope with any of the feelings that they're having. So I wish I had a magical answer as to how to prevent it, but I think that's still very much that's being explored in the literature, but I think it's really a big societal problem we need to address.
Thank you. I'll actually say that the Prevention Institute does have a resource on talking with very young children about their body parts, and just sort of helping parents understand what's sort of normal behavior. So if people are interested, they can take a look at that.
Yeah, that's great. And I would also kind of point back to that kind of protectingkids.ca website. They have a lot of resources that are similar to about kind of what language to use with their kids, what to teach your kids, what to go through. So resources for families, for parents, for schools. So kind of in addition, that's a good resource.
Great. Well, we're starting to get thank yous for the presentation. Thank you, great presentation. And thank you to everyone for attending, and hopefully you can share this with your colleagues so that they know that they will be able to view the webinar as well once it's up on our website. All right, thank you. Lots of helpful information. Thanks so much.
All right, thanks.
All right, thank you very much.